Probe. Probe. Needle.
Yes,
My
good
probe,
morning,
my probe,
everyone.
My probe.
On behalf of SaiShree Hospital and Arthrèx, I'd like to welcome you to this webinar on shoulder scopy and this novel technique which we are going to see today. I take this opportunity to welcome Dr. Abdul-llah Hachem from Barcelona, Spain, who has spared his valuable time to be here and to explain us his technique of especially fixing bony Bankart and Latarjet. So today, Dr. Sujit Kadrekar, our shoulder surgeon, is going to demonstrate a case of a bony Bankart, and which will be followed by a workshop and demonstration by Dr. Hachim. So stay tuned to OrthoTV for this interesting webinar. I take this opportunity to thank OrthoTV also for arranging this live telecast at such a short notice. So without wasting time, we'll switch to live surgery. Thank you very much and stay engaged. Thank you.
Okay. Good morning, everyone. So, good morning. I'm Dr. Sujit Kadrekar. I'm practicing shoulder surgeon in SaiShree Hospital. First, I would like to thank OrthoTV, Arthrèx, Avana for arranging this beautiful live webinar. So today's patient is a 22-year-old male with a history of trauma 1.5 years back. He's had a first dislocation due to road traffic accident. After that, he had around 8 to 9 dislocations, which was self-reduced by himself, which were painful. Last episode was 2 months back when he had severe pain, then got the MRI done. So MRI showed a labrum injury. So this is the arthroscopic picture. So if you focus outside, so we use not normal 3 portals, which is the posterior portal initially is the weaving portal, and there will be an anterior superior and anterior inferior portal. So anterior inferior portal is just above the subscapularis in the rotator cuff interval, and the anterior superior is just behind the biceps tendon. So here I can go anteriorly or the posteriorly, however I want, in case if there is a slap tear. So on arthroscopic examination, if you can visualize big Bankart lesion till around 5:30, 6 o'clock position. From 1 o'clock to 5:30 position. Probe, please. Probe, please. So on probing, we can see a big Bankart lesion up here. And if you see posteriorly, there is a shallow Hill Sachs. Probably not so engaging Hill Sachs lesion, which is seen out here. Now we'll shift my scope from a posterior viewing portal to the anterior superior viewing portal. Messenger rod, please. Small cannula ready. Small cannula ready. So on examination, apprehension was severely positive. Jobs relocation test was positive. On CT MRI, a bone defect of around around 15% is seen. Water pump, please. So I prefer doing it in lateral position. Bankart visibility is better. Pump, please. Cannula inside, please. So we have to go till the cannula is seen. Now we can remove it. Remove it. Okay. Favor, please. So from anterior superior portal, we get a proper bird's eye view of the entire glenoid and the Bankart lesion. Pro, please. Yeah. So this is how Bankart looks. As such, there is no bony pieces out here. It's more of a Bankart with the lip periosteal sleeve. So this is the bare area, center bare area, which we see. So from bare area to the anterior and bare area to the posterior border, it looks like around 15%. It's not a big bony loss. So we'll be planning a Bankart repair. Elevator. So we'll start with the steps of Bankart. It's usually a elevation of the ABSA, the periosteal sleeve. Till we start seeing the tissue of the subscapularis. Yeah. Go. So the important thing about repairing a Bankart lesion is lifting the tissue up. Oh. Right up till the 6 o'clock position. Okay, hammer, please. Proper release of all the tissues, all the adhesion. Go fast. Till we get a good sleeve which is lifted up till the glenoid. Okay, please. Go fast, go fast, go fast. Go. Perfect. So that's the sign of getting relieved. No, raspated. We get a bite first. Cannula, hold the cannula. Favor, please. So we'll try to clean the fibrous tissue as much as possible so we get a good healing bone. We get a good raw surface. So the soft tissue to raw surface healing will be adequate. Cannula, hold the cannula. Elevator.
Good morning, Dr. Sujit.
Good morning, sir.
Can you hear me? I'm Dr. Hachem.
Yes, Hachem, sir. I can hear you.
Thank you for inviting me, and thank you, Arthrèx, for inviting me to this wonderful webinar. And it's a great case. It seems we discussed before. It seems acute case because less than 1 year, but still have a good soft tissue with healed.
Yeah.
With healed, it seems to be good good tissue. So to remember that this is a young patient. He suffered 1 year ago the first shoulder dislocation with trauma injury, and after that, he dislocated his shoulder more than 5-6 times. Always he self-reduced the shoulder. And MRI, I don't know if the audience can see the MRI, but the MRI presented ALPSA lesions, a mixed lesion, because if you can see here, this is confirmed here in the arthroscopy from anterior superior lateral view. And this is a bony fragment, small bony fragment medialized, and it seems to be a fragmented lateral lesion in the anterior side of the in the joint, in the upper part of the labrum and in the inferior part. So Dr. Sujit, he was prepared this case. He do as me also lateral decubitus position, definitely for the shoulder instability, because we have now data about that. Nor maybe in sometimes in literature, the failure rate comparing repairing Bankart repair is much more higher than lateral decubitus, as you can see in this wonderful demonstration by our doctor. You can reach the anterior part, posterior part, the axial rebounds, the heel sac lesion from the, and with good vision from the anterior superior. This is, he switched quick from anterior to posterior. And now we are seeing the medialized heel sac lesion with a bone bridge between the insertion of the infraspinatus and the posterior area. Now he has debriding. He's debriding the cartilage to put the anchors to prepare the footprint of his remplissage. So as a good indication, now this is, we have a small bone loss, less than 10%, and maybe an off-track lesion. So this is ideal case for in multiple dislocation of the shoulder to do a remplissage plus Bankart repair.
Okay, so we are preparing the bed of the heel sacs. So we are preparing it for the remplissage. Lasso, crescent lasso. Okay. Okay. So till the anchor is open, I'll be just freshening the Bankart side. So the main important part is getting a raw bone as much as possible, so that the soft tissue healing to this is going to help us prevent future risk of dislocations. Anchor ready? Yeah, anchor ready. Okay, so I'll be using 5.5, 5.5 double loaded. Yes. So for the remplissage, I will be using 5.5 peak anchor double loaded. So I will be trying for the center of the crater instead of being edge. Being a shallow small helix, I will be using only single anchor. So I will be just putting the anchor and taking a bites. I won't be tying the knot. Counter, please. Mark gone. Okay, so the first mark is now here. Okay, so go till the first mark. Counter, please. Go fast, please. Okay, bus. So we'll be going for the first anchor. So I prefer the knotted technique. So I'll be using a crescent lasso for taking the bites in the infraspinatus. Okay, good hold. Okay, so I will be gently taking the cannula outside behind the infraspinatus so that I can start taking a bite here. This crescent lasso.
You can see here definitely the bone bridge between the heel sac lesion, heel sac defect, and the insertion in this view of the infraspinatus and the capsule. And you can see also the laxity of the axillary pouch from this wonderful view of ACL portal. So he introduced now one anchor with two loaded sutures with different color. And now he tried to bit and to introduce the penetrator, I imagine, through the capsule lateral to bring the suture lateral to perform the remplissage.
Water. Let's take the water.
In this case, what do you think? You need one screw or two screws?
So one screw I think would be adequate.
And how the decision making to decide to use one or two screw is it in your plan? I mean, seeing the MRI or CT scan, or
The MRI,
in
sir, and it's a shallow, it's not a deep lesion, and I will be using two double loaded suture. It's very bad. Here. Keep grasper ready.
now you are using the same cannula in the standard posterior portal.
Yeah,
You
I'm
do-
using the
you-
same cannula. I just withdrawn it, the cannula behind the infraspinatus, and so I'm using the same cannula to pass the lasso.
Exactly. And sometimes you introduce the screw from the cannula. So now he are working from posterior side with the same cannula, and he put the cannula outside the capsule, and he tried to the audience to understand that he tried to penetrate the capsule distal to the lesion and lateral. So now he are shuttling the suture, one suture through the capsule, and he tried to reproduce that
Loose
two or
view other,
more time.
view other. Hold tight other. So we are
And
just
here-
going to be confirm that we are not offloading. So we should be confirmed that the movement is occurring at the tissue level, not at the anchor level when we are pulling.
Now he shuttle the shuttle sutures from the anterior inferior portal through the rotator interval to exchange the suture to load to the lasso loop, the nitinol wire, and now you can see in the screen at the up side of the screen and the right, the outside patient. These tips you can use indirectly with suture lasso or a penetrator, direct penetrator through the tissue, and to retrieve the sutures from the posterior portal. This is as you wish, as you decided.
So we will just feed it again.
And one of the more important tips here, to keep the suture lateral to the defect and not too medial, because if you go with the suture medial and close to the posterior glenoid rim, you will lose too much external rotation in the post-op. In general, remplissage reduce less than 10 degree of external rotation in the post-op. So this is an important tip to avoid too much external rotation loosening.
Bird beak. Bird beak. The lasso is a little bit getting problem. So I will use a bird beak for time being till I get the lasso ready. Personally, I avoid using a bird beak because it's going to create blue.
Now you are using, no, doctor? You are using now.
Bird beak, integrate bird.
Exactly.
Second white, I move the blue one, hold the blue one. Okay. Hold blue other.
So it's very useful now. You can see how he was introduced lateral to the capsule. And he keep a tissue between the remnant suture and the new suture.
Retriever, please. Suture retriever, please. Beta, just be a bit cautious. Leave. Okay. Leave the other one.
So now you are going to do a knotted remplissage. With one anchor and 4 limbs with 2 sutures.
Which I put. Apply to that. Now the blue one I will pull. Yeah, leave the white now. Blue and white both I will pull. Yeah. Okay. Can we start again? So initially I used the bird beak. Now the lasso is back. So I'll be using lasso again. got it.
You have good space to use whatever you want from posterior, from back, lasso or a bird retriever.
Leave it, leave it. Sorry. Okay. Keep the white. Keep the white. Suture retrieve again. I will be pulling both white and blue. Leave it. Which was with artery? Which was with artery? This is the second one.
One tip doing a remplissage is to perform the configuration and keep it there, and now go to the Bankart repair, and
Yeah,
after
we'll
that,
do
at the end,
after this bite, yeah, sure.
at the end, you will not. This
I
is
can connect that. Okay. Both together. So after this bite, I will be going to Bankart repair, and in the
Yes.
end, I will be tying all the sutures. Okay.
now we are shortening the sutures. So there are still debates in the literatures and the available data about how many anchors we should put, 1 or 2, and how the loss of external rotation we will have in this with this remplissage, and how, and sometimes how you manage a double lesion of heel sac lesion, and still debate how we can debride the, if we need or not debride the bone bridge cartilage between the heel sac and the insertion of the infraspinatus. Of all, we have a lot of asking patients, asking questions, but in general, from available data, the remplissage is a good technique, and the results comparing without for the Bankart repair with and without remplissage is definitely much better and less failure rate with remplissage. And in the same time, maybe we have as comparing the bone block procedures for smallest glenoid bone loss, subcritical bone loss, and off-track lesion, it's the same available data and failure rates.
Okay, so now we'll be going into Bankart again, freshening the edge. Leave it. Yeah. Okay, so you have to be sure that all the labrum is lifted above the glenoid. Lasso, please. I will be taking a bite before.
The triple traction is very useful at this moment to do a Bankart repair. I mean, triple point traction is one from the arm in line of the arm, and the other is a second one without helping any assistant. With help any assistant, you can put it vertical traction with the all the companies have one, and Arthrèx have blue one with traction, vertical traction. Is very helpful to have to reach the axillary pounds with easily and duplicate the capsule.
So RF is a good thing if we get any amount of bleeding out there to control. So bleeding is good sign. That means we have adequate release.
Look at this view from anterior portal. The scope goes very medial. So if the surgeons do the instability working all the time with the 30 scope in the posterior
Please.
standard portal, he never can see this view. This is what we encourage every single surgeon to do in lateral decubitus position. This with anterior superior lateral portal to do instability.
So this gives a bird eye view.
Exactly. Unless you use a 70 scope from posterior, you can't see this good view from anterior superior portal. And as you have done, we should release all the capsule from anterior. Just look at this, perfect. We can see here in the bottom of the view, we see the fiber of subscapularis.
Yes, sir.
Exactly,
Start
perfect.
seeing the subscapularis
Perfect.
downstairs.
This is a subscapularis, perfect. And now he released perfectly until 5 o'clock. The assistant should be bring the arm but posteriorly.
Okay.
Exactly. Please, assistant, help him. Keep it the arm back. Exactly. Now he can test also. He can test with.
So first anchor will be at the 530 level. Yeah. Slowly lift it up. Go slow. Okay.
There are two manners to put the anchor
So we'll be
on the top or on the edge. So you prefer to put it on the top.
okay, so we'll be using Knotless fiber tack 1.8 suture.
It's a very useful tensionable suture. You don't
Tensionable
need-
sutures here.
You don't need to use a knot because everyone could differ in different situation to produce a strength knot, a powerful knot or not, and the difference between surgeons and the difference between inter-surgeons. So this is useful because this is the same time self-locking system. Now, after having introducing this one, so now he pull to reduce the.
So we'll be first pulling the W1 very suture.
He shuttles look at this. This knotless system comes with the two sutures. The blue one is for the tissue, and the white and thicker one with a look at a smallest one, thinner one, and the little bit flat one. You should transport the.
Okay. Now next we'll be taking a bite with the lasso. So I prefer taking it from the anterior portal only. So do you use the same portal or do you prefer putting your lasso from the posterior portal?
Like, no, I use the lasso from anterior portal, yes. And now, sometimes I use a retriever from posterior to reduce a little bit the tissue from distal to medial. While I introduce the first lasso, you can help us sometimes from posterior or a retriever as Kingfisher
So
to present the capsule, the anterior capsule.
So the inferior is always a little bit tricky and a difficult one because we have to do a capsular shift and we have to pull as much tissue as possible so that we get a good shift. Okay, we're ready. A good amount of tissue.
So you use also a suture lasso with the 45-degree.
Yes, a 45 degrees lasso. Usually
Okay.
prefer using 45 degree.
is very easy and useful to from the anterior portal. So now
So please hold the camera.
the anchor is a little bit proximal to the exit point of the lasso. So that means the tissue comes from distal to medial and from distal to superior. So this is a lasso now is distal to the anchor and the anchor is a little bit proximal. So this is that we'll gonna do a little bit shift of the tissue from distal to superior. This technology is mandatory for this technology to use a cannula for the instability to avoid any interposition with the soft tissue between
suture
the
which we have
lateral.
retrieved it, we'll be passing it from the lasso loop. The repair suture. This is a W1 is a repair suture.
You get a perfect kind of tissue from the anterior labrum. Now this is a suture pass through the tissue, and now the last thing
So,
is to pass this suture through the
Sally,
anchor.
can you focus on this now outside? So this is how the loading of the suture tag happens. So there is a tiger fiber tape and one white suture. So we load the white suture into the till the mark of the fiber tape.
It's very important to hold this suture at the end
1 minute. Yeah.
as much as possible. Perfect.
One minute. I will 1 minute. I will just pull the tissue a little bit. Rasper, can you just lift this up? Okay, 1 minute. Okay, relax. If you see the bite is adequate, the tissue is good. You can just pull the tissue out here. Okay, tighten it now. Okay, we get a good shift.
Perfect. Now you can see the attachment of the capsule at almost 5:30 hours, and now a couple of times or 3-4 times he can reduce. We can reduce.
Okay, so it's tight. So we have got a good capsular shift also. And as we
and
keep
sometimes
removing, you will get a bump also.
and sometimes it's recommendable, highly recommendable to use a knot pusher to do these tugs to reduce and to tension
Yes, sir.
the system. It's easy to do it, and you save time. And
We save
at the
time
end,
also. It is a low profile also. We don't get a big knot.
exactly. You don't have any knot between the head and the cartilage.
So it is not going to irritate the cartilage. Yeah, cut.
I call this system as a hidden sutures.
Okay. So as you see, we don't get a bit bigger knot or thread. which
Good
is going to
bumper, yeah.
irritate it. So second fiber tack. So we'll go with the same process. We'll be putting a second. So second anchor will be at the 430 level. So I prefer using at least 3 anchors. So so how many anchors do you prefer to do a Bankart repair?
You asked me, no?
Go. Okay. So can you hear me?
Yes. You asked me?
So yeah, so I prefer using 3 anchors at least. A lot of studies.
Yes.
A lot of studies shows getting lesser than 2 anchors, 2 or less anchors are a risk of Three dislocations, so three anchors. So how many you prefer to use?
Yeah, using I mean using a 2.4 or 3 millimeter anchor is true. 3 is enough, but when you use 1.8 millimeter fiber as this one fiber tack, I always my mean of number of anchor is 4 because it's 4. So I prefer to put the two as low as much as possible at 4 o'clock and 5:30, because the dislocations comes out as in distal, and my last anchor, my last anchor in the upper side is at the level of the subscapularis. So you are now maybe at 3:34. You could
So
put.
This is 5:30. This will be around 4 o'clock, and here third anchor will come around 3 o'clock.
Yeah, exactly. So this is what I used to use 4 anchor at least, because this is a soft and the smallest one. I prefer to put 4 anchor to have a good stability repair, and that means in the post-op I keep it only 2 or 3 weeks in sling
Yes, sir.
arm.
As
with sling
prefer
arm.
using so 3 weeks immobilization, and after 3 weeks we'll start with the pendulum exercises. So the bite always goes distal to the anchor so that we get a good shift. Pro, please.
Again, he transport the suture tissue, the blue one, to the posterior portal, and now from anterior portal he bit the capsulabral complex from distal to medial and from and to superior, distal superior and lateral to medial. And now he want to retrieve this nitinol wire from the posterior cannula to shuttle the suture tissue, the blue one, through this tissue.
Please hold, please. Hold the camera, please. You are ready. A lot of them, the fibrous tissue and thick tissues is going to prevent the lasso from. Yeah. So taken the second bite. Same procedure for fiber tag. So this is a repair suture. We retrieve it to the bite with the lasso. Only the thread part. Only the thread part. Leave it. Leave it. Okay. Again, if you can focus out here, how we are going to feed this thing. So if we feed the white into the tiger till the mark, till the mark, till the mark. Okay. And then we pull it. Going in. One bite. Okay. So in. So I will be using the suture retriever to just pull the tissue for approximation. Okay. Tighten it. Don't push the cannula. Okay. So one might just leave it loose. Sometimes it happens. So we just have to be sure that it is not getting locked inside. Can I put on here? Okay. 1 minute. I will just pull the tissue towards me. Okay. Pull.
It's very important to pull from the same portal when you introduce the anchor.
Yes. Sir.
It's much better to avoid and sometime, yeah, it's happened to me also. I tried in the beginning to do it from the posterior portal, but it's better to exactly from the same portal we introduce it, same direction. And now you can pull from the back to tension the
Yes. Sir.
tissue from distal to proximal.
Sir. Yeah. Nice tip noted, sir.
And it's yeah, it's good. And you can do it from the proximal to the knot also.
Not pusher. So the raft has the anchor has got stuck inside in between. The cylinder rod again. So my scope has just come out.
It's good to see that because it sometimes happen in the real life. So in direct also.
Better to happen it here. But yeah, we'll try to see how to bear it out. Okay. Fiber take and push lock, not push. We'll get, give me a lasso. Tip, fiber wire and push lock. Fiber wire push lock. One thread has been broken, unfortunately. Retriever, please.
You are repeating the procedures?
No, so I will be removing that suture. I will be cutting the suture. Artery. Hold it. Okay. I'm just preparing for the other. Hold it tight. Hold it tight. Okay. Another lasso. Okay. Can you give me a meniscus biter, please? Biter. And suture grasper, please. And meniscus biter, please. Lasso, wire, a new wire. Can you hold this? Biter. Hold this. Biter. Discuss biter, please.
Sometime happen this one because this is what happened when the suture comes in the posterior portal, anterior portal. So
Yeah.
this the mechanism is locked and blocked. This is what I've learned from this suture. Always is very, very kind application from the same portal.
Shiva, please.
He asked me, one in the audience asking, my preferred technique is to use knotless system. Knotless, yeah. After having used for many years knotted system, if you remember, if you use 3 or 4 anchor with a bulky knot, so at the end is when you revise these patients, you still can see the bulky knot between the cartilage and the humeral head and the glenoid. So if you, and another thing you have, the advantages of knotless system is a tensionable system is the same blocked system. I mean, the strength is the same for the blocked system. So it's useful and quick and save time, but it's very, very delicate to use, to understand, to don't do it changing the tension. The tension should be always from the same portal when you introduce it in same direction. So in some time, when we are going faster, so sometimes the suture from the tissue introduced in the loop before. So sometimes you should be careful.
Pottery, please. RF.
Will you keep all 3 threads in one cannula?
So any type of questions?
3 threads in same cannula or not less?
Yeah, this is the system comes from with three tails.
Yes.
One suture for the tissue and another one to transport the loop.
Yes.
One in the extreme is a loop. Another one is to shuttle this one.
So will you keep all of them in same portal?
No, so
When you introduce it, no, you should no, because if actually you should use as he did now, the suture lasso comes from the same cannula. So this lasso goes in the posterior side. So the shuttling, you can do it, but you should release all the nitinol and the handle out, and you can shuttle the same suture from the same cannula. You can use it with single, but it's too much. I mean, it's the direction. If you think about it, the direction of the nitinol wire is 180. So this is maybe will give a trouble. It's much better to use it to avoid these troubles, to do the triangulation between anterior and posterior.
So now I'll be using a push lock anchor for a second, just for demonstration.
As he did now.
Yeah.
So this is the suture lasso comes from anterior and the nitinol wire goes to posterior. So he shuttled now the suture from the same portal posterior to anterior. This is the loading sutures.
Suture retriever.
This is a suture alone, no?
So I'll be using a push lock anchor for this, sir. So I passed a loop.
Yeah, you can use instead to use a simple suture. You can use a fiber link with double loaded. I mean, in the loop, you can load the tails in the loop and the link at the end, and so you will have, when you introduce this suture in the push lock, you'll have two sutures for the labrum.
Sure, okay. The anchor, the drill, please.
Yeah, it's less than 10%. Less than 10%. Less. Yeah. Yeah, it's seamless.
1 minute. For space, please. Okay. Yeah, I will just readjust the sleeve position. Okay. A little bit, taking it a little bit higher because of the previous anchor. Okay, same direction, go.
Now you are using a 3.9, 2.9 push lock. That is the old one. This is the first knotless system.
Okay. Mullah. 1 minute, I will just. Okay. Just hold this. I'll pull, hold this. Suture retriever, please. The grasper. Okay, just put hold. Good push. Tap, please. Yeah. Tap, please. Yeah. One minute, just hold on. Okay, tap. Yeah, okay. Okay, yeah. So this is push lock anchor. Gives a good stability, so we can pull as much as possible in case of we want a good bump or we want to shift, pull the tissue up. Can you just hold? And just hold. And just hold. So this is also a low profile knot, so we don't get a big knot with it. You can use as flush as such.
So at the end, you combine two type of suture, but the same knotless.
Sorry, I didn't hear you.
I mean, at the end, you used two different system, but knotless, both of them.
Both of them are knotless. Yeah. So one was a suture tag, and second was a push lock anchor.
Exactly.
For fiber tag, sorry, fiber tag and
Push lock.
push lock anchor. So here I will be just taking a capsular thing for the proximal push lock. Suture retriever, please. Okay, so again I will be using a knotless push lock anchor. So what's your note on push lock anchors? Hachem, sir. Am I audible? Am I audible?
What's he asking? Yes, you are going to use a second push lock, no? But now
Yeah,
with a different
I'm
color
using
of
one more
suture,
push-
tiger. You use tiger suture. Do you have here fiber link to use it?
Fiber link? No, sir. Not here.
Then for the future, you can ask for fiber link to do this, to push lock. Is very easy also.
Okay. So the last anchor, third anchor, I will be putting it at around 3 o'clock. Okay. Yeah. Yeah. Going in? Yeah. Okay, so we just have to be precaution, take care that the soft tissue can cover the hole, and then it will be a difficult position to keep searching for the hole. So try to keep this jig as much as possible till your assistant load the threads in your anchors.
Yeah, you can use it also a nitinol wire temporary to don't lose the hole. You are doing a good reduction.
Okay. Check. Perfect. Yeah, excellent. Pull the threads. Okay. Yes. So I usually take the anchors a little bit 2 mm inside the face so that we get a good bump.
Yeah, you reach a good bone, good bumper.
Bump. What this? Rope. Cutter. So if you see, the head is now centralized, which was subluxed anteriorly.
Definitely. And you can see here we are commented before a little bit detached, not detached, there's a little bit lesion of the posterior labrum maybe.
So if you can see a good shift.
Yeah, good glycation of the tissue. Good.
So it's mainly the good shift is there. So the inferior capsule is tightened. Plus, if you see, the MGHL is also attached and tight. As this, the labrum superior to the 3 looks okay. So I'm not going to put any anchor out here about 3 o'clock. So usually this ends our Bankart repair. I will be then shifting to the further Emphysage repair. Just the last flight is pending. So which bite?
Excuse me, someone in the audience asked for if you repair or exam the posterior labrum.
So posterior labrum is okay, just fraying of labrum. Okay. Maybe because of multiple dislocations, there is fraying, but it is attached out here.
It's still attached. There's a little bit
Sure.
divided.
Posterior labrum is okay. Posterior labrum is not detached from the glenoid.
Exactly. Is
So I won't be going to repair this thing. Okay. There is just gentle fraying of tissues seen here. Lasso, straight lasso. Straight lasso. Again. Crescent one. Where is the crescent one? I will require the crescent lasso again. Okay, so if you no, so if you see this will come, the infraspidus will sit in the defect comfortably. Sujit, please. That's why you take a bite initially before you fix the Bankart, because afterwards you don't get space to take bites. But the tying will be later on. One minute, hold on. So this is the tissue. Hold it like this. Leave the mosquito. Leave the mosquito. Leave the mosquito. डबल लिया था, एक सिंगल वाइट बाकी है.
Exactly. From the audience, a comment of the audience also here in the room, one surgeon say he preferred to use a needle to shuttle, as you say here, as you used also, without bird. Yeah, the same as lasso, suture lasso, because this is a smallest hole in the capsule. There's another tip to use for the remplissage, needle with the PDS suture loaded in this needle and to shuttle suture through the capsule.
So leave the blue one. So now all the bites are taken. So first I have taken a single blue one. Then second bite I have taken a blue and a white, and the white one, just to prevent any blue, please, blue. So if you see, once you start pulling, tying the knot, the infraspidus will get stuck. So initially I will be tying the blue one. A lot of time I don't visualize it knot. I will just visualize it later on.
So you have now the 4 limbs.
I have the 4 limbs. So
Yeah.
I'll be tying the blue one first, the posterior bite, which I had taken.
So now you are tying the capsule, and the arm is which position? Neutral position, external rotation,
It's a neutral position.
neutral position. So this is very important to prevent the loss of external rotation.
External rotation, yeah.
There's a good view of the feeling of the remplissage of the tendon, capsular tenodesis of the defect with the first anchor and the first knot. Thanks. Yeah, sorry.
Not better. So the defect is getting filled.
The problem when you use the same cannula and 4 limbs in the same cannula, sometimes you will have a little bit stuck knot, and you have, and sometimes you will have a stuck, I mean, in with the suture doing the same cannula.
So I'm using the same cannula, just I'm being behind the infraspinatus, and I'm pulling the tissue through the cannula.
So again, you retrieve exactly.
Suture equal, keep the suture equals.
You took out the cannula and again exactly to avoid the stacks.
Yeah. So now I'm tying the anterior one to fully closed effect. Okay. Okay. I'm using a simple half-inch knotted.
Yeah, I used a simple
Yes, sir.
alternate a one pulse and alternative half features 5 or 6 times.
Okay. So head is centralized. Nice amount of capsular shift and bump here. And the heel sacks also is got closed.
Did you check your stability leaving the weight from the arm and check the translation in stability?
So remove the weight.
This is what I used also. Yeah.
So
You
I'm just
check it, you can check it now, and this is
the
very
traction.
stable. Without traction, yeah,
the traction is removed now.
exactly. And now
Okay,
try to
bend the elbow. Hold the thread. Okay. So externate it. Slow. Okay. So it's not going up.
very
So,
stable.
yeah,
Perfect.
it's very stable.
Perfect. Well done.
Thank you, sir. Thank you very much. Now just close it. So we have learned push lock anchors and knotless fiber tack. Any questions, sir? Other questions?
No, it's good job. Good job. Well done. I mean, now how many times you keep it in the arm in the
So
sleeve?
I will keep him immobilized, totally immobilized for 3 weeks.
3 weeks.
But after 2 weeks, I can just gentle elbow movements and short pendulum exercises can be started. After 3 weeks, we'll start with the full proper long arm pendulum exercises and active assisted ROM exercises. Gradually, then I will shift him to a TheraBand exercises and strengthening protocols.
Perfect. It's very important to start from the beginning with isometric deltoid contraction and isometric.
So from day
retraction of
one,
the
we
scapula
will start
muscle.
with the scapular sets and isometric exercises. But short arm pendulum exercises will be starting after 2 weeks only. Suction, please. Okay. Thank you very much, sir.
Thank you very much for it's well done. Good job. And you finished now, no?
Okay, so we'll now we'll proceed for the workshop. And I will join
Finished.
you in 5 minutes, sir.
So good job and congratulations.
Thank you very much, sir. Thank you. Yes.
Hello, Ali. 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 Rohit. Rohit, can you hear me?
is here. Where's the mic? Still not working. Not okay.
Anis, Anis, you can hear us?
Okay. Just 3 minutes. So, put it, well, you know, what is the system? Put it here, please. One, yeah, put it here. Yeah, assist me. Okay, put it here. So, yeah, ready. This is a case, typical case, when the graft is 20 millimeters and the defect is bigger than 20 millimeters. So if you use a coracoid process, never you can take more than 20. So this is less than best fit circle. The best fit circle came here. So this area still don't have bone. This typical case. It is good. Yeah, right? 5 minutes, yeah. It is, how many time we have? Okay. So, good morning, everybody, and thank you for inviting me to this meeting, Arthrèx and OrthoTV. So now I'm going to share this technique, bone block cerclage technique for anterior glenoid bone loss. So we did here glenoid bone loss, almost subcritical bone loss. That means maybe 20% of the defect. I draw here the bed fit circle to see to understand how our defect is. So in general, we need to measure the anterior. Do we have a stay? We need to measure the before doing the bone block technique. The scope it's here in the superior portal. So from the superior portal, using an anterior instrument device, you could measure this length, the length of the defect of the anterior rim. So in sometime I used to use 28 or 30 millimeters of length, and the tricortical bone loss comes here. So this bone graft is 20 millimeters. So this is, if you measure here the defect, look at this, the anterior rim, it's almost sometimes is in bigger patient. This is a big scalpel, big glenoid side. Look at this, the defect is almost 28 millimeters. So in these cases, when you use if you use as graft a coracoid process, it's almost we can obtain 20 millimeters only. This is the same as this one. So we could cover the inferior part of the bed fit circle here. If you imagine the line here comes here from here to the bed fit circle, and you still have lost bone here in this side.
is what in the majority of cases with big defect, you can't do it with a graft obtaining from the coracoid process. So now we have a small graft today. We don't have a 25 millimeter of graft. So we're gonna go to show you how we can use it, fix it, this graft without metal. So the technique, it comes with to use tape cerclage. This tape cerclage with different color. The tape cerclage comes from the company loading with by this system. A new system is a plastic one. This is two tape cerclage, two tapes in the same length. So I could show you now before starting the tape. There's two cerclage as you can see here, and here one blue and one tiger cerclage. So we have now four tapes. We should pass the four tapes with the same length in each tunnel. We're gonna go to perform two tunnels in this glenoid defect. So now the new guide design. Can you see? Yeah, the new guide design is for anterior glenoid bone loss is in the upper posterior side is the fixed angle, and the angle is changed here. So the anatomic angle here, look at this one here. So this angle is between the drill bit and this guide, the hook. It's to have anatomic reduction and anatomic support to the glenoid. So in the hook, you have two marker here, two marker laser mark to have a 5 millimeter tunnel or 7 millimeter. The guide is here. The rocketing hitch system is It's easy to introduce, and with two lengths, this is a marker here, 5 millimeter, and if you take out and turn off the guide, you find the 7 millimeter tunnel here. 7. So, and this is laser mark also to determine the length of the distance between the end of the drill bit and the hook. So you can control every time how many length you have inside the joint with this laser mark is outside the joint. So it's come with the handle as a gun to use with one hand to support it, and with its rocketing hitch system, and to release it by pulling here small pressure here, and it's out enough to smoothly sliding inside the reel. So now in Bibo, we do is we take out the drill sleeve, and I used to use from the posterior portal, the camera is anterior as superior lateral portal. So I introduce a switching stick. I put a sliding above the switching stick as a hemicannula. I keep the hemicannula here and take out the hemicannula. I take out the switching stick, and I put the hemicannula. I slide above the hemicannula, the hook from posterior. So if we need to cover, I mean, when we have excuse me, I take out my mask. So when we have a huge defect, if we decided to use a tricortical bone graft with 30 millimeter or 28 millimeter, we could put the hook in the middle of the defect. But in this case, remember, we have a smallest graft. So should be, if I put my hook here, I know this two line here, laser mark, determines the exit point of the tunnel. So the exit point of the tunnel, the distance is between both is 1 centimeter. If I put here the hook, the graft goes here. It's a little bit is higher for the situation. Remember the dislocation, the dislocated shoulder, it comes from 2 o'clock, 2:50 o'clock until 5:50. So, and if you want to see the direction of the line, the the line of the Bellvitge circle, so the graft should be at 5:30. So the middle of the middle of the defect is here. So when you use this defect, when you use this graph, so the middle of the defect is here, a middle of the graph. So look at this, is a little bit, we are less than the equator. So from posterior, in general, we put the measure here, and from posterior with the cobulator, we mark our center of the defect or our center of graft. Imagine, I believe, is that to plan this surgery. So I introduce, as I said, above the half pipe. We put the now the hook in the middle of the defect, and in this position, look at this. We still have. We could remove, change the angulation, and so this is angulation and this position. We still have switches. So we should have. We keep in mind this anatomic guide should be in contact, full contact with the glenoid surface from the posterior to anterior, not a smallest movement as 1 millimeter or 2 millimeter could change the exit points and the offset, the final offset here between the exit point and the anterior glenoid rim. So now, after this position, we introduce the drill sleeve from posterior here. What do I have here? 5 millimeter. No. Zoom out. Let it zoom out. Zoom out. Enough. Perfect. So I introduce here, from here. Yeah, zoom in now. So now we should have a full contact between here. Look at this here, the safe guide, because when you have this anatomic guide in contact with the glenoid, never you will be more than 10 millimeter from the posterior glenoid rim. So the nerve comes here. Look at the nerve. The nerve comes 1.1 centimeter and half at least, and it's between 1.5 and 2 centimeters. It's very far from the posterior glenoid rim. So this is the key. The first thing, we should put this guide, this anatomic guide, flush to the cartilage, and this drill sleeve should be in full contact. We feel it in full contact, and it's at the end we can leave it in this position and very stable. Look at this. But still, we can still change this movement, a little bit movement. But when the drill sleeve is in contact with posterior glenoid wall, and the hook is here, is in contact with anterior, is very stable. So at this moment, we decided the length. So we started with our first tunnel. I recommend in this position, the scope comes from the anterior superior portal, sustained by the assistant, and the same surgeon introduce the drill. And look at this, still have this movement. So zoom in, please, zoom in. Here, in. So exactly, perfect. So now, at this moment, as much as possible, parallel to the surface and in the posterior part. Put it in forward. It's reverse. No, still. Okay, now. So this is, we should have here the first tunnel, it doesn't matter. We can do the distal one or proximal one. Now we release this one. We should have take care to have this one very tight, the neutral wire to above to avoid any soft tissue inside the drill bit. So at this moment, we still have this small rotation. Look at this, but not in this position from inclination, but you still have. So if we change this angulation here, we could have an exit point different offset to respect the first one. So the second one, now the new set jig comes with different lengths of the drill bit, but now we have the same length. So it's a good help from someone to put a mosquito with your finger here. Oh, it doesn't matter. You put your finger here at this position. Yeah, exactly. It's the same as your mosquito. This is your mosquito here, comes here. And now, again, the surgeon support the guide. Yeah, touching here. Yeah, out, no problem. So now out, yeah. We can see just a minute. Yeah. Oh, okay. No. You should put the camera here, please. Yeah. Differently. Yeah. No. Just a minute. We remove the drill bit now. Yeah, because here is this. So now at this moment, we release the neutral wire inside the drill. Zoom out, please. Out, please. So at this moment, we release the drill sleeve with here a little bit button here. And in this position is very important to, in some weak bone, to avoid the retrieve of this drill bit, to slide the drill sleeve outside the smooth movement. And now at this moment is lateral movement, this position, and to keep it the switch the guide, and in this position we take out the guide. And now, so we can now measure the exit point in the glenoid side. Now this here, exactly. The exit point from, is very important to know what is your exit point from the tunnel to respect the anterior glenoid surface and the cartilage. This is offset. We should match this distance to the graft. So now we shuttle from, zoom out please. We introduce neutral wire here. I don't know if you can see. Now, is this one, exactly. With one loop anteriorly and the other posteriorly. Put the loop here. Here, the first loop is here anteriorly, so the second one is posteriorly. It doesn't matter now. It doesn't matter. This is the most important thing is at the end. At the end, because we shuttle the loop now. So now, once we have these two suture to transport, so we can remove now our drill bit from posterior, the same for the other one. And now we should exchange this nickel wire with two suture with loop to transport the tapes, because this is a hard tape, and maybe in sometimes to avoid any breakage for this nickel wire. So we exchange this one with the fiber link. So the first one, hold please. And now, it doesn't matter, we can start it in the upper part or the inferior part. So now, we exchange the first one. At this moment, I recommend to put, because we have here, this is a posterior standard portal, and this is from anterior inferior portal or rotator interval portal. So I keep it here, both the same suture, to avoid any switch, any twisted of this suture inside the patient, with exactly with a mosquito. And the second one, so it was different color. So keep it in mind. One loop anteriorly and the other one loop posteriorly. So this is the first one we put. What we put? The link is anterior. Exactly. And loop anterior. So the second loop is posteriorly. So we can shuttle from anterior to posterior. It doesn't matter. The thing is, an important thing is to have it in different directions. So now, the second one. So at this moment, before to introduce the graft, we should dilate the rotator interval. We should cut always the labrum if we didn't do it in the beginning at 1 o'clock, to have a smoothly sliding of the graft from this rotator interval. We keep safe and without any damage to subscapularis. And I used to put a syringe of 20 millimeters. So now at this moment, we take both suture fiber tape cerclage, and we keep it with the same length all the time. As I said, we now have four tapes. Remember, for the surgery, so different surgery, we have the same length. In here, in this demo, we have the different lengths. This is for the fracture, because the bigger one or white one is we used to the fracture is very long, and the actual for fiber tape cerclage is short one. So it's very important to shuttle now from posterior with the same length using the first loop. The first loop is posterior. It doesn't matter if it is distal or proximal. So now we shuttle both loop with the same tunnel. We can use 2 millimeter 0.4 or 3 millimeter. So now this is anterior inferior portal. This is from this position, in general this position. Here this is exactly, this is the cannula, or without cannula we can do it. So now we shuttle the suture. The first, I call it this, the first strip. As much as possible, we put very close to the skin at this moment, the preloaded card or cartoon. So we keep it here at the same length. So now we don't have a measure. So in general, the offset we decided is 5 millimeter. But before I didn't use it, before introducing this tapes, we can use it before to measure this distance. Could we put here the camera, please, to find the offset here? Yeah. As you can see here, we have a mosquito. See, it's here. No problem. So look at this now. I put the guide at 5 millimeter. Too many. Yeah, zoom in. Exactly. So the exit point regarding to the anterior glenoid is, in this case, is 6 millimeter. Yeah, just a minute. It's 6 millimeter. So, and from the proximal one is 5 millimeter. So you should match this distance to in the graph. So we decided this graph, mark it. So, and in general, the graft have a cortical bone. So the cortical bone should be here, anteriorly. So this is a surface bone, surface for the, this is, we mark the tunnel. And now from the cancerous surface, we should mark the introduction of the graft. So we goes now here, please, here. So now this is a Glenoid surface. Look at this. From this is Glenoid surface, this is a distal tunnel. So I realized my exit point was a 6 millimeter. So I introduce as much as possible in the center of the graft, 6 millimeter here. This is cartilage surface, little bit eccentric. So, and the other one with 1 centimeter of the distance here, as I marked before, 5 millimeter. This one, 5 millimeter, so little bit, 1 millimeter up. It's easy to be accurate and to have the flush to the surface cartilage. So now, with the same drill bit, and we have here a center of the drill bit. Look at this. This is a key wire to fix the cancerous surface from the cancerous surface. And if you have a big graft, you can go in the middle. But in some time, it's recommendable to put it little bit divergent in the opposite side, in the cortex, to have a good bridge between bone, to avoid any rupture of this bridge bone. So now, up. Okay. Now, the second one. Okay, much better here. So the second one is little bit 1 millimeter up. So it's reverse. Forward. Okay, perfect. So now it's very recommendable to have a small, no, not this is a demo, so a smaller drill. So now we match it. This is cancerous surface, and this is lateral surface. So we should mark now the level of the tunnels, as you can see. So now, the first one, here. Okay. Perfect. So now, the sutures comes from the cancerous surface. Okay. This is the cancerous surface. This is you can see the graph. So we are in the distal tunnel. Tapes in this case the first tape is in distal tunnel. So we should match this distal tunnel with the distal tunnel from the graph. We could use a nitinol, but you don't need it because this suture is very hard. So we pull, and we keep the graft very close to the skin, Here, perfect. So as much as possible, the same length, always same length. With the tension, if we keep it very tensioned and the same length, we will avoid every slacks. So now, from the cortical surface here. Again, the third tunnel, first tunnel, second tunnel, third tunnel, and you keep it all the same length. We can pull from each tape to have the same length. Don't worry about this one. The most important thing is to have it, keep it, please, hold this one. Look at this, what's happening here. This is in real life should be happen. So keep it the same length. This is very important to have tension in every single tunnel with a tension suture. Now, look at this here. This is a bridge between the two tunnels. This is a cancerous surface. Yeah, avoid the bright. Yeah, exactly. So now this is a cancerous surface here. Cancerous surface, articular joint tunnel. This surface will be in contact with the cartilage of the humeral head, and this is a bridge between the graft. You can see it now. This is yeah. Zoom. Exactly, perfect. So now we go to the last. Hold this one, please. Hold this. Keep it here. Keep it here. So the last trip, I call it. We shuttle this suture tapes, 4 tapes from anterior, from the rotator interval to posterior. All the time at the same length, as I said. So now, at this moment, very important tip. We should pull from backside from all the tapes at the same times, in this manner. This is here, this is the scheme. So from here was the helping, and we can introduce this one in the rotator interval. We should put it in this direction as an arrow. So maybe you can help with the hand or some mosquito, but it's very important now. I put a syringe of 20 millimeters. It's smoothly introduced in less than 30 seconds. Yeah, this is only to introduce this one. No, don't do it. So now we introduce this by pulling from posterior, pam, 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 pam. At this position, keep it there, leave it. So it directly goes along to the anterior surface. Look at this. Still, in normal patients, we put this one very close, and now only by pulling from backside, look at the stability. Only by I mean holding this suture, look at the stability here. It's very stable, very stable. So now, in the beginning, we started without interconnecting the suture, but now it's very important to interconnect the suture. And the suture comes in the same length, as I said. So now, focus here, please. So now, the suture, the blue sutures and the white one should interconnect. So the first one, this is a blue one, and this is the blue one. I know, yeah, you can see it in the here. This is with the blue one, and I now introduced the white, the thicker one in the blue one. So it's easy to introduce. And this is a holder. Look at this one. I introduce this one, and after that, we remove this one easily from this. And this is rocking a hitch knot. And now the loop is here. We should maintain this loop outside the patient. This one, please. So there's another one. In general, comes in the same length as this position. So we have now different lengths because we are in demo. So now the blue one is introduced. Hold, please. Is introduced again. Smoothly inside the knot white one. So now we release this plastic holder. And now again, by pulling from the other, in this color blue one, we should have, look at this now, what's happened. In real surgery, in some time you have smallest loop with big loop. So we, in these cases, what we want to do, in these cases, by pulling from the other loop, so this one, by pulling from this one, we reduce this one, the bigger one. So by pulling, we don't need to pull in this position. I mean, both tape individually. We pull, look at this. And what's happened, so keep it there. Keep it here, this one, please, with your left hand, exactly. Look at this. When I pull from individually each tail of this cerclage, I reduce the bigger one until we will have the same length of the loop of tape. Perfect. Now we check it. The same length also, a little bit more. It's very important. If you do it in this by this manner, you will avoid any slack in the system to avoid the stacks. So now, hold this one, please. Alternatively, alone, small loop. Hold this one. And now keep it separated, please. Again, pluck. Hold this one, please. This was your assistance. Smallest movement, alternatively, symmetrically. Try to have the same length. All, look at this now. I have here, look at this. This tape, little bit longer than this one. So by pulling one, I reduce the same length. It's important to have to avoid any slacks. And you feel at the end the knot, it's against the posterior glenoid wall rim. You feel it because I can't remove it now. It's stopped. We have here now to put the guide one incision parallel to the inferior scapula, spine scapula. Not in this position. I mean, the patient is there. So in the beginning, we did in this position. Now we do one incision, horizontal incision, parallel to as much as possible, close to the bone to put the guide here. So in this position, now we can introduce, if we want, the small finger to touch the knot above the glenoid rim. So now at this moment is enough. So now to be sure we don't have any slack, we cut this suture tapes comes in unit. So now we separated this one and we check again the sliding tapes by introducing the tapes in the hole. Can say it, okay? In the hole, one tape in the hole and the other one in the open hole. So we put it against the posterior glenoid wall. So now out here, please, here. So look at the hole here now. We introduce the two tapes in the hole of the tensioner only to be sure we don't have any slack. So now we put it against the posterior wall, and this marker here, you can see it because it's, yeah, it's 20, 40, we need only 30 pounds, not in Newton. That means every single pound is 1.4 Newton, 4.2 Newton, excuse me, sorry. So 30 pounds is enough. Yeah, well, now we are sure we reach almost 125 Newton. So at this moment, we should exactly see the loop all the time, the bridge. So enough now. We release by pressure here. We release the tapes. We repeat the same action with the other color of the tape. We cut the suture, we introduce in the closed hole one, and the other in the open hole from the tensioner. We push against the posterior glenoid wall to be sure. And again, we introduced in the eyelet and hole from the tensioner. Again, 30 pounds. And while I put 30 pounds here, the scope should be goes here. Please, to the anterior glenoid bridge. Zoom, perfect, perfect. Look at this now. So if you don't see any sliding of these tapes, that means the system have not any slack. Finish. So now we should started to the blocked system. So we decided which one we want to use as a post. We do a half hitches, and this half hitched with the do you have a knot pusher? Knot pusher. So we use a knot pusher to slide down this knot against the posterior wall. We maintain our post in our mind with a mosquito. So now the new protocol, after having done multiple trial in the lab, we keep the post aside, and we introduce our half hitches in the closed eyelet tensioner. So now the system comes down. The tensioner comes down, and now again we goes to 30 pounds. At this moment, again 30 pounds. We are looking and noted the cerclage. Now again, please, the camera, always the camera, our scope, not at this moment. Our scope always should be here to see the bridge between, to avoid any rupture of this bridge, because we can't control which bridge of this bone is weak. So now again, 30 pounds. At this moment is in dry is perfect because we don't cut anything. Now I have 40 pounds. I feel the tensioner is very hard now, very hard. So enough. So this is a post now, our post. We continue to secure. This is alternatively, I did the first one, now I did the second one. We slide, hold this one please. So we slide with the knot pusher, three half hitches. So this I did my second one. No, this is what I want to put here. This is in the post, not in the. Our knot pusher should be in the post, not in the half hitches switches. So this is, I have it now. So I did 2-1. So the third one is equal to the first one, and the fourth one equal to the second one. Alternative is enough for 4. Now the system is locked in one time. So I keep it with tension without cutting, and I do the same as I did for the first knot. I introduce a knot pusher in one suture limb to keep it aside with a mosquito. And now we do our half hitches again, half hitches, and we slide it to the posterior wall. We keep it aside, and again we tension in the closed hole from the tensioner. In the eyelet system. So again, 30 pounds here, please, and seeing always, this is the last time. So now the first system is locked here. So now when I pull and use a tensioner, the system is very, very closed and stable because the last one we are pulling from all the system, but with the knot in the other side. This is the last thing, and you can feel the high tension slowly, slowly, one by one, and now seeing all the time here, please. The bridge, exactly. If you sometime you could feel a little bit broken, you will stop. And look at this now. It's impossible to remove this one. Now we're reaching 40 pounds. And the same, this is my knot pusher here. Again, I use the second half hitches, third half hitches as the first one. I mean 1, 3, and 5. If you want 2, 4, and 6, as I used all my life for the knotted systems. So now the fixation is finished. We can cut both with a knot cutter, Bushito cutter. So, and now look at this now. It's very stable. We send now a paper from we did in cadaver lab 10 Cerclage system with the Latarjet comparing to 2-button system individually and suspensory system, and to comparing to the screw. We found a high. Look at this. The head comes down and push the graft inferiorly. It's very, very stable. And believe me, in live surgery and in live patient, we don't have any movement of this one. It's very stable because this is here is so bone. And look at this. I can't move it. I move it, but in this case, in cadaver, it's a little bit. This movement is from not here, from this saw bone. So this is after that. The capsule is maintained here in this position as a pouch. So I cut I release the PDS suture to maintain this pouch, and I reattach the capsule, by pulling from the capsule from anterior portal or anterolateral anterior portal. Sorry, I reattach the first anchor here, the second anchor here, the third anchor, and the fourth anchor. I put fourth anchor, and now if you can see, if you draw here, this is small best fit circle. Our graph is less than the best fit circle, and to study this one, look at this. This area, the lateral area, the far area from the cartilage, always is outside the best fit circle. So this is in the when what we found in the on our outcomes, this area always disappear because we don't need, because it's under the low flow. This area we don't work. So at the end, the shape, the final shape at 2 years is this bone here as the normal shape of the glenoid. So that's it. Thank you very much. And I hope you will understand, you have understand this technique and all these tips. Thank you very much. Thank you, OrthoTV. Thank you. Very soft. Yeah. In real life,
हेलो अली, हेलो हेलो।
हेलो सचिन। हेलो हेलो सचिन।
हेलो।
हाँ हाँ
बस।
सचिन।
हाँ हेलो। हाँ हो गया।
हाँ हो गया हो गया।
ओके ठीक है, ठीक है,
ठीक।
फिर मैं लाइव स्ट्रीमिंग बंद कर रहा हूँ।
हाँ ठीक है चलेगा।